Okay, intracerebral or intraparenchymal hemorrhages, again, classically elevated ICP. The big difference here when we're talking about intraparenchymal hemorrhages, if it's isolated to a lobe or potentially a couple lobes, and it's in an elderly patient again. So in other words, if we have an elderly patient, we're thinking subdural hematoma or lobar hemorrhage. If it's lobar hemorrhage, it's classically associated with cerebral amyloid angiopathy. That's particularly high yield. Okay, and again, these, because they're lobar, they're intraparenchymal, they do usually present with focal neurologic deficits. If the temporal lobe is involved, look for uncal transtentorial herniation, which I'll talk about in more detail in a slide to come. But that, again, early finding of that would be anisocoria because of a dilated pupil, and potentially you might have like the down and out pupil with the ptosis, okay? The key thing also to remember for these is there's a very high tendency for recurrence of a lobar hemorrhage. All right, and then lacunar hemorrhages, I feel like we've talked about this a couple times. Charcot-Bouchard aneurysms are classic. You get the fibrinoid necrosis from the chronic hypertension, the chronic hypertensive vasculopathy, and eventually these are prone to rupture. Putamen is a very classic site, also the thalamus. Internal capsule, we talked about the findings for internal capsular lesions. It can be anywhere from a pure motor lesion. Sensory lesion would be more classic for the thalamus, but can also be observed in internal capsular injury. And like I said, I go through this in much greater detail in the stroke lecture, so you can look for that if you're looking for more details on this. And the basal ganglia, I also talk about bradykinesia, tremor, chorea, all talked about in the stroke lecture as well. So these would be very classic for more of the lacunar hemorrhage. The thing about lacunar hemorrhages is usually you won't see cortical signs like aphasia, neglect, that kind of thing.